Hello, hello. Okay, we're recording. Hello, everybody. We're just going to wait a few minutes here as folks file in, and then we'll start up with Alexandria's presentation. Oh, should I let Dr. Newcomer in? I think probably.
Yeah.
Hey everyone,
Hey,
Hey,
Sophia.
Sophia.
how's everyone doing? I'm excited for this. Jim, would you like, after you get it started, do you want me to introduce Alexandria as her dissertation advisor?
That would be amazing. I'm sorry I
Okay.
didn't think of that.
No,
Yes.
it's okay. I would love to do it.
Okay, thank you. All right, people are flying in now. Hello, everybody. We'll get started in just a second. Maybe we'll give it one more minute. People are really rolling in through the waiting room here. Okay, everybody, I think we'll get started. I'd like to welcome you to the first seminar for our seminar series this year with the School of Public and Community Health Sciences and the Academic Health Department here at this in Missoula. I'm Jim Karinji with Dr. Chase Begay. I'm some of the hosts and organizers for this event, and we're really excited that you're with us. I'd like to thank Carolyn Hester for really stepping in and helping us out with this because as some of you may not know, Patrick Dye has moved on, and those are some very big shoes to fill. So without taking any more time, we have an excellent presentation today that we're really excited about. I'm going to hand things over to Dr. Sophia Newcomer, who is Alexandria Albers' advisor.
Yeah, hi, good afternoon, everyone. Great to see you on Zoom. I'm just really excited to introduce Alexandria today. Many of you know Alexandria. She is a PhD candidate in the PhD in Public Health program. Alexandria had a ton of work experience before coming over to the public health world. So you might not know that she has undergrad and master's degrees in biology. She did quite a bit of work in animal health before making the transition over to human health. And in fact, back in her bio days, she taught biology at community colleges. Um, but she made the switch over to public health and human health about probably 5 or 6 years ago was when she started with the MPH CHIPS program. That's when I first got to meet her. And I've been really excited to work with her and partner with her on research projects. In particular, Alexandria has been working as a graduate research assistant on my R01 project listed here, which is focused on looking at trends in childhood vaccinations in the US. But as you'll see today, Alexandria has really taken a line of this work and is leading it on her own. And is doing some really important work around really looking into some nuances into how we measure childhood vaccination uptake in the US. I'm going to say one more thing before I give it to Alexandria, which is I want to brag about her really quick because I don't know if she's going to mention it, but her first paper from her dissertation, which I think she'll talk about a little bit today, her work on looking at invalid vaccinations given to children, was conditionally accepted to the journal Pediatrics after initial review. And some of you might be familiar with that journal. It's a very high profile journal. I've never had a paper conditionally accepted after the first review. So the reviewers had some really outstanding things to say about that work. So with that, I'm going to turn it over to Alexandria.
Thank you, Dr. Newcomer. Yes, so as I think many of you on the call know, I'm Alexandria. It's nice to see people kind of at the beginning of this school semester. So today I'm giving my research update, which is the second of kind of your 3 big presentations during your dissertation. So hopefully I'll see you again in March for the third one. But today I'm going to be talking about my dissertation, in particular, my background of the dissertation and really setting up how I got to my overall objectives and walking you through my first 2 aims. I do have results on those first 2 aims and laying just some broad kind of framework down for my third aim and how I'm planning to approach that. And the analyses for that are just now kind of getting in the works and getting into really thinking about how to approach that third aim. So to start really broad, in case you were not aware, vaccines are really an incredibly effective public health tool that we have, not only for decreasing disease rates and disease transmission, but also from protecting all ages against severe disease. And I'm particularly interested in vaccinations during early childhood, which is where this dissertation is focused, in children under 3 years old. This age group is not only vulnerable to severe disease and severe illness, but they're also an interesting group because of the prevalence of pathogens that they naturally carry at that age, and then how they interact with other children and other people. They're a really big contributor sometimes to disease transmission and can be a really important group to get vaccinated and to figure out how controlling disease in young kids can help us control disease for all ages. And partly due to this, children are recommended to receive quite a lot of vaccines. Actually, currently, they're recommended to receive 12 different vaccine series by the time that they're 24 months or 2 years old. And so all of this really funnels down to how we get vaccines to children because of all these factors is really critical. And then how we are able to then identify and measure if we're doing this well is also really important to public health. So if we zoom in on this piece of children are recommended to receive 12 vaccine series, who's recommending them? So the recommendations are through the Advisory Committee on Immunization Practices, or ACIP as they're commonly referred to. And the ACIP are experts, they're groups of experts of various types, including pediatricians, immunologists, and they put out the ACIP recommended childhood immunization schedule. And it literally looks just like a schedule. And they say which vaccines children under 3 years old, here it's from birth to 24 months, which vaccine series children are recommended to get. And as we'll talk about in just a minute, exactly when they should get it, how many doses, and some other factors. But I do want to just draw our attention to what children are getting recommended to get vaccinated on now, to just start kind of the conversation with these different vaccine series. So RSV and COVID-19, which is a little bit below mid line here, were both recently recommended on the schedule, but the rest of these have been around for a little bit. So hepatitis B, rotavirus, DTaP is diphtheria, tetanus, and acellular pertussis. Hib is Haemophilus influenzae, a type B is specifically. There's a pneumococcal vaccine, a vaccine for polio, flu or influenza, measles, mumps, and rubella is MMR. Chickenpox is referred to often as varicella in the talk today, and then hepatitis A as well. So a lot of different series and vaccine preventable diseases that children are recommended to get protected from. So how does the ACIP make these recommendations? So they consider multiple factors, but the ones I want to talk about today are vaccine safety. They also consider immunological development, particularly for this group of children, but also epidemiological trends of disease all go into their recommendations to not only say what they should get vaccinated for, but also the number of doses children need to complete series, when each dose should be received, and then they have this set of age parameters. So there's a minimum age recommendation for each vaccine dose, but there's also a maximum age recommendation actually specifically for rotavirus vaccine. And then for multi-dose series, there's a minimum time that should be allotted in between doses. And then there's also an ACIP catch-up schedule, which the ACIP puts out for specifically for children who have either started late or they're starting to get some multi-dose series late. And it's just to help get kids literally caught up on these series. All right, so how do we actually track, though, if children are receiving vaccinations in the US? And so if you don't know, this is done through the National Immunization Survey Child, or NIS Child. And this is an annual phone survey where parents and caregivers of children who are 19 to 35 months during the time of survey are called and asked about not only factors about their household, for example, but particularly for vaccine history of children from birth until whatever age they are at the time of survey. This is the way national surveillance of vaccination coverage is done, is through NIS Child, and it's conducted and sponsored by the CDC. And then the vaccination coverage estimates that are derived from NIS Child are eventually reported in the Morbidity and Mortality Weekly Reports, or MMWR reports. And this is just a snapshot below of exactly what a report might look like when it comes out. So this is one for vaccination coverage by age 24 months that came out in October of 2021. And in this report, I want to show you an example of how vaccination coverage is actually reported on. So this is just to look at one. And so I went ahead and chose DTaP. And so this is using NIS Child Survey years. And this in front of you here for this first row would translate to 81% of US children are up to date on DTaP, meaning that they have received at least 4 doses of DTaP, which is the recommended number of doses according to the ACIP to complete a series by the time you're 2 years old. So this other one on the screen here is combined 7 vaccine series. And this one is actually saying, okay, so now we're saying 71% of children are up to date on 7 different vaccine series. And in particular, the 7 series are DTaP, polio, varicella, hepatitis B, MMR, pneumococcal, and Hib. And so, yeah, so those 7 series are what's covered in that combined 7 vaccine measure. But what's missing here? So really a lot of these factors of how we would think about ACIP schedule adherence is missing. So when to receive each dose, these age parameters, and then of course there's nothing about the catch-up schedule in the way these measures are reported. And I'll also add, we don't have a combined metric for all vaccines. There's just those 7. So just to kind of recap, we're doing great with number of doses. We have those in the reports. That's definitely covered. A lot of Dr. Newcomer's previous and current work is looking at the timeliness of receiving vaccination doses. So that piece is really being unpacked currently. And my dissertation really focuses on these other pieces here. So my first aim really looks at if you're receiving these doses outside of age parameters. And then the second aim is looking at a particular part of the catch-up schedule, while the third aim is creating that combined metric for all vaccines that are recommended. So my dissertation objectives were to first refine national vaccination coverage measures to really more accurately reflect how vaccinations are recommended to children in the US. And then my second objective was to illuminate factors that are associated with how this ACIP schedule is used, whether it's adherence or deviations from. And throughout the whole dissertation, I'll be using National Immunization Survey Child, or NIS Child, data. And just to remind you, this is the national surveillance done to get vaccination coverage at a national level. I'll be using that same data set. These data are publicly available, and we will only be looking at provider verified records. So although in the survey, parents are asked about their child's vaccine records, they also give permission to then send not like a worksheet, but like to send to the providers to fill out for vaccine records that are then sent back. And those are the data we're using. We also will incorporate weighting to actually have national estimates in our vaccination coverage measure. So you will hear me say % of US children, and that's why we're able to do that, because of the multiple factors that go into weighting with NIS child data. We also can account for complex survey design with strata and cluster variables. The range of survey years will be from 2011 to 2021 over all 3 aims. And I just want to point that out because even though right now in 2024, children are recommended to receive 12 vaccine series, during this study period time, there were only 10 on the schedule. Again, COVID-19 and RSV won't be included in these analyses. But all other vaccine series will be. So for the first aim, that was those age parameters. So my main goal here is to quantify prevalence of children who received vaccinations outside of these age parameters. And so how this looks on the actual schedule, I'm just giving you an example of 3 vaccine series here with when doses are recommended to be received. And so each dose actually has a minimum age that you're not supposed to get vaccinated before, according to ACIP. And then every multi-dose series has a minimum interval in between doses. And then for rotavirus in particular, those doses each have a maximum age associated with it. And if you do not meet these age parameters, then the ACIP has said that those doses are actually invalid and they need to be repeated. So what we did was we started with NIS child data from 2011 until 2020 survey years. And this picture here on the right is just a snapshot of the fact that we're able to go to the NIS child website for each survey year and pull those data. And that comes with data users guide, the actual questionnaires parents and providers receive, and then the input statements depending on what programming language you're using. So the first thing we wanted to do was describe invalid doses. And so we wanted to do this first, like overall, how many children nationally are receiving an invalid dose, but then also across survey years per every vaccine series, and then also looking at it at each reason a dose could be considered invalid. And then we wanted to see of children who had an invalid dose, who then received those recommended repeat valid doses. So the first thing we had to do was go through all the prior immunization schedules which applied to our study period And we had to create parameters that matched what these kind of age parameters actually were before we could apply it to the data. And this ended up in a pretty big table. I'm just showing you a snapshot here as an example. So again, for DTaP, this is a 4-dose series recommended by the ACIP. The minimum age and days each dose would be received for DTaP, and here for PCV as well, would be 38 days, would be the minimum for that first dose. You can't be younger than 66 days to get that second dose. And then on the right, this is that interval. So between dose 1 to 2, you need at least 24 days before you get that second dose. So that's how we formed these parameters. And then we applied them to all children, all vaccine series in the data set. And we were able to flag doses of vaccinations that were outside of these minimum ages, or for rotavirus, also a maximum age, but then also flag doses outside of that minimum dose interval spacing. And we quantified the prevalence of children that had at least one invalid dose. And then we pulled those kids and said, okay, of you who had an invalid dose, how many of you then received extra valid doses? And you might be asking, why are there extra doses? And children can absolutely have more than the recommended number of doses in their vaccine records, with one of the reasons being because they are recommended to have doses repeated. And when you have an invalid dose, and if you do get a repeat dose, that invalid dose will still stay in the medical record. It doesn't just get deleted. So we'll have all of that to look at. And we just really wanted to give kids as much like credit as they could towards completing series with valid doses. So we also looked at factors associated with receiving an invalid dose. And for this, we used a multivariable logistic regression model and kind of an exploratory way of just trying to see what factors, which are collected at the time of survey, they're mostly demographic, household, and provider factors, are associated with receiving an invalid dose. So what we found is, well, first of all, our study population was 161,187 children, ages 19 to 35 months at the time of survey with provider verified records. And we found that 15.4% of US children did have at least one invalid dose. However, this did decrease across survey years. So from 2011 to 2020, with some fluctuations in the middle, of course, but overall, we did see a decrease in the percentage of US children with an invalid vaccine dose across survey years. So then when we think about what is the prevalence of children who had an invalid vaccination dose per vaccine series, that's what this graph is showing. And we'll walk through a couple examples here. So of all vaccine series, the highest prevalence with children with an invalid dose was the 3-dose rotavirus vaccine series. And more specifically, when you look at children who had an invalid rotavirus dose, 70% of these invalid doses were due to receiving the first dose of the series after the maximum age parameter. And this is interesting for a couple of reasons. So the first being, it kind of goes against your ability to quote unquote correct this dose. So if you've already received it after a maximum age, obviously you don't get younger as time goes on. So giving another dose won't fix this problem. So that isn't really a solution. And the maximum age was actually put in place because in the early 2000s, when rotavirus was initially put on the market and on the schedule, there was a very small association with increased risk of intussusception in children if you got that first dose late. So they pulled that from the market. 2 new ones came out a few years later with better safety profiles, and but they did tack that maximum age parameter on it. So it's kind of an interesting one that's unlike the others. So I wanted to draw our attention to that. And then the second most prevalent one was the 3-dose HIB series. And before I go into this one, I just want to point our attention to the fact that HIB can actually be a 3 or a 4-dose series, depending on what brand of vaccine you're getting. And so 4-dose kids are getting this at 2, 4, 6, and 12 to 15 months. And 3-dose kids, that 6-month dose is not required or for completion. So that comes into play when I tell you now that of the kids who had an invalid dose in this 3-dose series of Hib, the overwhelming problem here was that the 3rd dose was given too young, so before the minimum age. However, when we look at repeat doses, 84% of these kids did receive a repeat valid vaccination, which essentially like addresses this invalid dose. Addresses the invalid dose. And so what we think is happening here is that these 3-dose kids are actually being vaccinated on more of a 4-dose schedule. And so that 3rd 6-month dose looks invalid, and it is technically, but they are getting that corrected and getting that 12 to 15-month dose that is kind of their 3rd dose. So here we have an issue that is high prevalence when we look at the percentage, but is a problem that might not be contributing to a lot of increase in disease risk, for example, which is a little different than this next one I'm going to show. So for hepatitis B, here we found that the 3rd dose of hepatitis B being given before the minimum age was the most common problem for kids with an invalid hepatitis B dose. But we only found that not even 15% of these kids with an invalid dose received a repeat dose that's valid. And this is kind of different than when we're seeing with Hib, where we were having a lot of repeat valid doses. Here, a lot of these kids are getting that final dose too early, and then it's not being fixed. So here we might talk more about disease vulnerability. So really what we learned from this descriptive piece is how important it is to consider the type of invalid dose associated with thinking about public health implications. So whether the invalid dose is repeated and valid, or whether the invalid dose was not repeated and these kids might be remaining under vaccinated, or how do we think about this concern with maximum age violations? But we also looked at factors associated with receiving at least one invalid vaccination. I'm just going to give 2 quickly here. So the first one we found that was associated was if children moved across state lines. So this was associated with 1.5 times the odds of receiving an invalid vaccination. And so these are kind of speculative and not something, of course, that we were able to directly measure in this study. But if we're trying to think about why this would be associated with an invalid dose, 2 major things that I think about is if you're moving across state lines, especially for that interval between doses, if you don't have continuous updated records with you when you move, it could be harder to get that timing right. And then potentially, since we have some maximum age issues of rotavirus being given too late, maybe there's something going on with how primary care is established when you move. But of course, we weren't able to directly measure that in the study. And then the second one is if you received all vaccines in a hospital-based facility versus a private-based facility, you had 0.8 times the odds, so slightly reduced odds of having an invalid vaccination. And a thought that came up with this one is if kids are receiving all their vaccines in a hospital-based facility, there's a good chance that it's a well-resourced large hospital, and that those resources like electronic health record system, maybe coupled with use of clinical decision support at time of care, might really help increase record availability, or even if you go to another clinic within that system, and you're just able to increase the chance that you're going to get an invalid vaccination, or not get an invalid vaccination, but get a vaccination on time. And then, so that kind of wraps up the first aim with thinking about all of these age parameters, but now we're going to move on to thinking about, okay, so now if we exclusively are thinking about kids that start really late, and what are these kids doing? So this is kind of a shift. So for my second aim, the first thing I want to do is differentiate between what I mean when I say routine versus catch-up schedule again. So the routine immunization schedule is that first schedule I pulled up in the background. It's the on time schedule. It's kind of the ideal way if children can get vaccinated, that they get vaccinated. And the ACIP catch-up schedule is particularly for children who are starting series late or getting those multi-dose doses later than recommended. So our goal in this aim was, we approached this as we really wanted to figure out if the ACIP catch-up schedule was being used, and for a couple of reasons. So one, we just really were unsure if there was adherence or not to this particular ACIP catch-up schedule. And these kids might have kind of a unique period of prolonged disease vulnerability that we just hadn't been measuring before or trying to intervene on. And so we wanted to start understanding that better for these children. And it's potentially these children are actually masked in current coverage measures in the way that we do it. And so we're not really able to identify how to kind of make any issue better if they're getting late vaccinations such that they're initiating this schedule. We can't do a whole lot if we don't know if it's happening. However, this is tricky with survey data. We have retrospective data. We have data that have already been collected. The vaccines have already been given. So we're not able to follow children to say, okay, so you started late. Now I want to see how this progresses. And we also can't ask providers this is this child's vaccine profile. Can you walk me through how you use the catch-up schedule or if you didn't? So those types of things are not available. So there's some level of kind of inferring if they're using the catch-up schedule. But what we were able to see is that when you look at the catch-up schedule recommendations for hepatitis B, hepatitis A, varicella, influenza, MMR, and rotavirus, the catch-up recommendations actually are the same as the routine recommendations, particularly for the number of doses recommended, and the interval in between doses is also the same. It just starts when that child starts the series, or begins again when they start, if they start another dose late. But that wasn't necessarily true for DTaP, polio, PCV, or Hib. So for these vaccine series, it depended on when, what age vaccines were received, but it was very possible that depending on how old these children were when they were getting vaccines, that the recommendations might actually totally change. And it could be the number of doses changed, and also the interval actually recommendation changed. Unfortunately, for DTaP and IPV, particularly for poliovirus and DTaP, this doesn't happen. These changes don't happen until the child is they're getting primary series after 4 years old, and NIS child only goes through 3 years old. So we couldn't quantify that in the data, but we could for PCV and Hib, because the changes can actually start in the first year of life. So those are the ones we focused on in this aim, were PCV and Hib. So then the next thing we had to do was translate this ACIP catch-up schedule. So the ACIP catch-up schedule is given in such a way that it's trying to help providers at point of care decide, okay, I have a child here, and what is their vaccine history, if they have any, and how old are they now, and then what's my next steps? So it's very prospective. So we had to figure out how to translate that into a way to then analyze the data to see if it's fitting within the catch-up schedule. So that was kind of our next big step, is to do this for PCV and for Hib. And so what we were able to come up with is that children who routinely, and I have the routine schedule for PCV and Hib up here just to remind us. So routinely for PCV, children are recommended to get 4 doses. For Hib, this is that 3 or 4 dose series. If you're a 3-dose child, you don't need that 6-month dose. So that's the routine recommendation. But we found that particularly if you're initiating series at age 7 months or older, it's throwing you automatically into that catch-up schedule. And often you're then going to be recommended to actually receive fewer doses to complete series, which is kind of interesting, but also a way that we could quantify that this was happening in the data. So that's exactly what we did. We found how are you completing PCV or HIB? Are you completing in 3, 2, or 1? And are you initiating so late that you're actually being kicked into the catch-up schedule? And one other note here, PCV and HIB pretty much have the same catch-up schedule. The big difference here is that 1 dose, you can complete in 1 dose for PCV after 24 months, but for HIB, it's as young as 15 months. So a difference there for how you can complete those series. So we use National Immunization Survey child data again. This time we went from 2016 to 2021. And we first just wanted to quantify the prevalence of children who are actually initiating these series at or after age 7 months. And then we wanted to know if these children were actually having any other opportunity to initiate these series. And opportunity was defined as receiving another routine vaccination from age 6 weeks to 7 months. So were there any other routine vaccines being given when they weren't getting PCV or HIB? And then we wanted to identify the prevalence of late initiators who completed PCV or HIB based on the ACIP catch-up schedule. So were they then completing in 3, 2, or 1 dose? And then we also looked at factors associated with initiating PCV or HIB late using a multivariable logistic regression. And I approached this one a little differently. I'm showing here 3 main exposures that I was interested in: facility type, insurance type, and then moved across state lines. And I used directed acyclic graphs or DAGs to help inform what I needed to adjust for when I was looking at each of these exposure outcome relationships. And I ended up adjusting for income to poverty ratio, race and ethnicity, census region, and survey year. So what we found is that in our whole study population, we had 99,652 children in the whole study. And then I'm going to break this out for PCV and for HIB. So we found that 2.5% of US children had initiated PCV at or after age 7 months, and 2.3% of US children initiated HIB at or after age 7 months. And the median age for the first dose was 384 days for PCV and 407 days for HIB. Now, I think the most important takeaway for the median age is that, so both of these are recommended to be started at age 2 months. But here, when you're initiating late, so late that you're kicking the catch-up schedule off, you're actually initiating after you're a year old. So after 365 days, right? So pretty late, even compared to the 7-month threshold for the catch-up schedule. And then interestingly, so in neither of these series did the majority of kids have an opportunity. So 35 and 27% respectively for PCV and HIB had an opportunity to actually receive PCV or HIB, meaning they weren't getting other routine vaccinations from 6 weeks to 7 months old. However, when we looked at who completed based on the catch-up schedule, we found that 77% of PCV late initiators and about 88% of HIB late initiators were completing the series by the time they were 36 months old, according to the catch-up schedule. And most commonly for PCV, kids were completing in 2 doses, and most commonly for HIB, they were completing in 1 dose. And this last piece is probably related to PCV. You have to be 2 years old to complete in 1 dose, versus HIB, you have to be only 15 months. So that could be some of reflected in this number. So overall, like a low prevalence of children initiating late, which is great. However, when they are initiating late, they're initiating after a year old. There's not a lot of opportunity beforehand necessarily, but they are completing according to the catch-up schedule. So then when we looked at factors associated with initiating PCV or HIB late, the 3 major ones that come up are public facility, receiving all vaccines at a public facility versus a private facility, if children were uninsured versus privately insured, and then if children had moved across state lines versus not. These all were associated with higher odds of receiving or initiating PCV or HIB late. So taking all of that together, I have some big considerations to talk about. Now, I'm still thinking through these. I still want to talk to collaborators about kind of how to interpret some of these data. But right now, where my mind is going is I first want to say public facilities are very critical for vaccination. And I don't think that something is happening at a public facility that's like causing kids to initiate late. I think it's probably more of a proxy for other things, potentially the way primary care and medical homes are being established. It seems like, particularly because opportunities were not present beforehand and some of the factors associated, that maybe some really targeted work to getting kids into primary care or a medical home sooner is important for this late initiation. And then being uninsured is kind of, that's definitely one we can talk about for a long time, and why it's such a barrier to receiving health services in general. I think particularly for vaccination, this one comes up consistently because you can't always remove the financial barriers to getting vaccinated. Kind of, even if the vaccine is no cost, there are many other barriers to actually getting that service. So that requires a lot of work still. And then finally, to wrap up here, I want to just frame how I want to do this third aim with incorporating some of my first two aims as well. So if you recall, this third aim is having a combined metric of vaccination coverage that is for all recommended vaccines. And just to remind us some more, so this was the one where I had shown the combined 7 vaccine series. And the 7 that are included, again, are DTaP, polio, varicella, Hep B, MMR, pneumococcal PCV, and then Hib. So for the 10 that we're looking at in this dissertation, it's actually excluding rotavirus, Hep A, and influenza. And just to show you how these vaccination coverages kind of maybe compare to what's included and what's not. So this is the combined 7. This is at 70.1% coverage that we've already seen. But these are all the 7 that are in that combined 7 metric. And we see it ranges from 80% for Hib all the way up to 93.4% for the poliovirus vaccine when you break it out by series. However, again, when we say kids are up to date on all 7 of these, of course, this percentage is lower. And then comparing that to what's currently excluded, so hepatitis A, influenza, and rotavirus. So these are even a little bit lower than the vaccine series in the combined 7. So we may be underestimating vaccination coverage overall, right? But it would be nice to have a gauge of all the recommended vaccine series. So I need to create that measure and then measure vaccination coverage. And I do want to do this in what I mentioned as the dose counting methodology, counting up if you're up to date based on the ACIP recommended number of doses, because I would like to compare it to what the CDC is getting for their combined 7. But then I also want to incorporate how coverage estimates change when you consider invalid doses, right? So really incorporating that work that I've done on the first aim and how that's going to influence vaccination coverage. I think a catch-up schedule, like small sub-analysis, would be interesting, and if that has influence on this. But I also have to be really careful here because I don't want to accidentally start advocating for late vaccine initiation. So it would be something that would be very distinct, but something that could be interesting to explore for sure. So the goal with this dissertation, again, is to kind of refine these measures based on all of these other ways that we think about ACIP schedule adherence. And I really hope to see you all in March 2025 when I am, in fact, defending, and I can give you an update on that third aim and maybe a little bit better of an analysis update on that second aim as well. And I have so many people that I could thank and acknowledge. I'm going to leave it until the spring. But I do want to acknowledge my committees on the call today. And thank you, everyone, for all the time that you have helped me put into this and have put into this. And it's a journey, and I'm still here. So that's great. But this meme, I think, sums up how I'm currently feeling as a third-year PhD student from Michael Scott. So I would love to take your comments, questions. Thank you.
Thank you, Alexandria. It was excellent as always. I learned a ton. Questions, everybody. You could either take your camera off and unmute, or put your camera on and unmute and ask your question right here. Or you want to put it in the chat, that works too.
I'll be your Huckleberry. So great presentation, Alexandria. I'm so happy to see you at this stage, and it's so exciting. A few questions, like one, I mean, what can you tell us about the difference in terms of outcomes like mortality, morbidity, that sort of thing for folks that get off schedule as opposed to folks that stay on schedule?
Yeah. Do you want me to address that one first? I know you said you had a couple.
Sure.
Okay. So this is a great question, and particularly, so I will say for the second aim for those late initiators, so this really hasn't been looked at before. So I don't have an amazing answer for exactly how those then influence disease outcomes across any time of their life. What we do know is more about what under vaccination, how that generally kind of plays into particularly outbreaks is the first thing that comes to my mind to answer your question. And so the most work that I can think of that's been done, particularly recently in this, is with like measles cases and things like that. So when you look at measles outbreaks, there's a very high percentage of, and it's not always children, but people who are under vaccinated or unvaccinated in particular. And so I think to most directly answer your question, the thought behind like, okay, so what about these people or these children who aren't getting them on time, is we're worried that then they don't have as high of protection against these diseases, and that it's either contributing to less community level protection or increasing their personal risk of disease severity. So most of it's going to go back to that kind of outbreak data that we have.
Understood. Thanks. And I really appreciate you like bringing in the nuance in terms of like public and private facilities, insurance status, and that sort of thing. And what you have here is absolutely a great dissertation topic. And so I just want to offer a comment, like 5, 10 years from now, whenever, I mean, look downstream and think about ways to maybe incorporate, I don't know, I'm an ethnography kind of guy, you know that. I
Yeah.
mean, what happens in these public private facilities? What happens in terms of people having insurance, not insurance? What's the lived experience of that? And how does that impact these vaccine schedules? It's too much to put on your plate right now, but I really encourage you to think about that as you move along in your career. And thanks for a great presentation.
Yeah, thank you so much. That's a great comment and something I'm very interested in. Thank you, Gil.
Other questions?
I'll come
Dr.
across the line. I'll ask a question. Um, well, and actually I'm going to ask you something that I don't know if we've talked about it, but with AIM 1, were you surprised by what you found in terms of the prevalence of children who received at least one vaccine dose too early, too soon, or too late in the case of rotavirus?
I initially was surprised that it was higher than I was expecting, closer to probably 10%, just based on early work that has been done. So I was surprised a little bit, but the rotavirus one, I think for that issue, it not only surprised me, but the rabbit holes then that it created for me to go down and really understand how we get from a vaccine being put on the schedule to then looking at vaccine safety data, and then how it goes when one gets pulled, and then how that then can affect or not affect how we're measuring this years later. I think that was a really important just kind of lesson for me to learn, that I'm measuring it. However, it's so important to think about like how the invalid dose actually got there, and kind of tying in with what Gil was saying. So I think I was more surprised at how complicated some of these invalid doses ended up being, is I guess what I'm trying to say. Yeah. That it's not just as simple as you were too young, but there was like hidden reasons in it.
Yeah. Yeah. And I think that's right. And I think a lot of like because you've presented this work at conferences and you've presented it with our collaborators, and a lot of the questions end up being like, well, why is that recommendation like that? You know, like, why do we have that maximum age for rotavirus? And like, why is there a minimum interval between Hep B? And I'm wondering if when your paper gets published, if it's going to kind of continue some of those conversations, prompting some of those conversations in terms of like looking at the schedule. I'll ask one more question. But can you talk for a little bit about like what your suggestions are for your AIM-1 in terms of like what could be done to like increase adherence to ACIP recommendations, which, as we were just talking about, can be rather complicated for nurses and for providers to follow?
Mm-hmm. Yeah, so I think, there's kind of some, what's the saying, like low-hanging fruit that you can talk about. And I think one of the easiest ones to think about is, okay, so if invalid doses are happening, exactly what at the point of care level could increase the fact that, like, knowing exactly if that's too soon or too late. And so one way that has been talked about is to try to focus on increasing electronic health record system, and also if you have clinical decision support, which is from the CDC has had that since 2012, specifically for immunizations. But the problem with that is that only for clinics who already have that infrastructure to then use an electronic health record system, that have the staffing to do that. So I think not only for invalid doses, but when we're talking about ACIP schedule adherence period, I think of it from a much more like health infrastructure kind of system level. And so I think not only do we need more equity-based ways to get the communities kind of involved with how primary care is established, how medical homes are established, but also getting clinics who maybe could use or want to use or have the training to get more technology to their clinics, but doing it in a way of focusing on who has nothing and building them up from there. And that's a really big answer and not easy to do. But I think, I'm in a dissertation. I guess I can think big right now, right?
That's right. Right. Thank you.
Mm-hmm.
Do we have any other questions?
Sure, I'll go again. So
right.
I was just wondering, do you have any sense of how the United States compares to other countries in terms of like keeping folks on schedule or not?
I don't have a great sense, and that's actually something I would love to spend a little more time, because I think the differences because there are schedules in other countries, and they're slightly different than how we recommend. And I think that in itself is interesting, because people are always curious, like Sophia had mentioned, like, why do we have the recommendations this way? And so there's some things to unpack there. I have seen some research coming out where they're kind of testing the differences in like immunologic response based on the different schedules to see if there is some difference we need to consider. But as far as keeping on track for childhood, I don't have a great answer for that. But there is a pretty interesting example out of Australia for the HPV vaccine, which is in adolescents, so a little, outside of mine. But and I believe, and Sophia, correct me if I'm wrong, this may have been through mandates, but Australia has done so well with HPV vaccination, has had such high vaccination coverage. They fairly recently, in the last few years, have been able to declare that HPV is not in their population anymore. I believe that's correct, but they've had really high vaccination coverage rates contributing to that. But part of that might be mandates as well, which we could talk about for sure. Pros and cons of that.
Thank you.
Yeah.
I'm a guest here, and I want to thank you for a wonderful presentation. I also have my grandson on my shoulder, so he's very interested as well in the immunization. The one thing I would raise is when you take a look at comparing delivery systems, consider looking at the Israel system, where they have what's called Tipat Chalav. You may be aware of it, where they've completely separated out the immunization process from everything else. And children from the beginning are immediately enrolled in local, not even local clinics, local, I don't know what you call them, but they make sure they get all their vaccination. And it's separated off from other well child care or sick child care. And it's an interesting model that involves lower level practitioners.
Oh, thank you. That's a great recommendation. I'll look into that. Because that also, we talk sometimes about at least trying to maybe get established who the child will see during prenatal care. But then that also, that assumes prenatal care that assumes that's only for that population, right? Those getting prenatal care. But anyway, something like that would be interesting to look into. Thank you.
Thank you again.
Yeah.
Any final questions?
Hi, yeah, Alexandria, this is Becky Weiner. I work for the Department of Public Health and Human Services, also just sort of a guest in this talk, and this was great. Thank you. A lot of things to think about. One thing that I was going to ask is, have you taken a look at the use of IMTRAX or our immunization information system as it pertains, especially as you were speaking about clinical decision making and what we actually call a forecaster within the IIS, and how that might kind of work in your future work?
Yeah, so thank you for that question. I have not looked at it in this project. I would love to. And I think that's definitely something we're advocating for as a team, is really being able to do this at a better, with a state level system to really answer the questions for your communities, for an area maybe a little smaller than the national level. And I think that is a really important next step. So I haven't done it, but I would love to, or somebody definitely should.
Yeah, so we work with Dr. Sophia Newcomer quite a bit. If you have additional questions, she knows how to reach us, and I'd be happy to help in any way.
Oh, great. Thank you.
Anyone else as we wrap up? Okay, well, thank you very much, Alexandria. This was excellent, and congratulations on getting this far so well in your program. It's really impressive. Want to thank everyone for coming and tell you that next week we have thanks to Dr. Quintero, we have a really interesting presentation from the PIRE Research Group in New Mexico. Dr. Daniel Shattuck will be presenting on the issue of the unhoused. And the title is Understanding the Lived Realities of Young People Impacted by Precarious Housing and Other Systemic Harms in New Mexico. And as many of you know, the Academic Health Department has been focusing on the issue of houselessness. So this will be an excellent kind of compare contrast to look at what's going on here and there. So again, I want to say thank you. I want to thank Carolyn Hester, Chair Kimber McKay, for all the help that you've given us as we try to live without Patrick Dye. So this was really, really awesome. Thank you, everybody.
Thanks.